Good afternoon. I'm delighted to be with you to speak about health disparities in cancer prevention, screening, and survivorship. I'd just like to go over a few of my disclosures. You can see the grant funding I receive from that is actually given to the institution, and my appointments. I just rotated off the Ohio Commission on Minority Health, and again, I'm excited to be with you this afternoon. Here's an overview of what I'm going to be speaking about. First of all, I'm going to go over a definition of health disparities so that we're all on the same track. Then we're going to talk a little bit about why there are disparities. Then I'm going to overview, a very high-level overview of the areas in prevention, screening, and survivorship that we know that we can do something about. And lastly, I'm going to give you some real examples of what we're doing to address health disparities in Ohio. And first of all, in this section, I'm going to give you a little glimpse of Ohio and our communities. Then I'm going to talk about a couple of tools to address disparities that we are using. One that we call continuum of care, patient navigation. And the second, how technology can aid in reducing disparities in survivorship. And finally, kind of be my conclusion, I'm going to present to you a program that we are beginning to implement in the state of Ohio called Turning the Page on Breast Cancer, which really highlights everything that I will be talking to you about today. And then we'll have some time for questions. Okay, let's start with a definition of health disparities. So disparities mean differences in risk factors, in incidence of a disease, and in outcomes of a disease that should not exist. It's very important, the should not exist part, because there are differences that should exist, but disparities come into play when there are differences that should not exist. And these differences are manifest in different populations that we often term as being underserved. And these populations are defined as women, those who are at younger age, those who are older age, racial minorities, ethnic minorities, populations of lower socioeconomic status, rural populations, or LGBTQ plus populations, and handicapped populations. And I love this cartoon at the bottom, which describes the difference between equality and equity. Here we see inequality. Everybody has the same bike, but some people are tall, some people are short, and then we have our handicapped person who can't ride that bike. When we talk about equity, we give people what they need to all achieve the same outcome. And what they need is based on who they are and what their needs are. So here's a great example of a disparity. Okay, again, disparity, differences that should not exist. Should not be any difference in death rates. These are cancer death rates by sex and race. And you can see the lower line is white females. The x-axis is year of death, and the y-axis is rate per 100,000 population. The red line is black females, and you can see there's already a disparity there. White males and black males. That comparison, you can see the disparity overwhelming with black males. Yes, the disparity is narrowing, but there still is a difference that should not exist, thus a disparity. So why are there disparities? I love this cartoon from the American Association for Cancer Research that was published in their Cancer Disparities Progress Report last year. So there are disparities because of complex and multi-level factors that interact. And these factors are, in some cases, influenced by structural and systematic racism. So because the causes of disparities are multi-level, the solutions to disparities must also be multi-level. And as you're identifying the reasons for disparities and the solutions to disparities in a specific community or population, it's very important to include the view of the community. Now, there have been many models developed to address disparities, both to understand and then to intervene. And the socioecologic framework models, I like those models. They focus on these multiple levels. And I'm going to show you now an example that we developed from the Centers for Population Health and Health Disparities, which was a collaboration of investigators from several centers. Now this is the model, and you can see the purple box on the right, disparities, disparate health outcomes. And they are a result of the interaction of both upstream factors and downstream factors. Upstream factors being social conditions and policies, which with institutional factors are fundamental causes. The next level in the middle are the social and physical context, and the bottom level are the downstream factors, individual demographic risk factors, and biologic responses and pathways. Now, I'm going to show you an example because these are just like big words, and so I'm going to give you an example, discrete examples in each of these boxes. So in this model, we are looking at disparities in death rates from breast cancer among African American women. Why? And it's not just because the second level purple factor that women, African American women, have lower rates of mammography, because actually that's not always true. So let's look at the risk factor levels and then we'll go into intervention. So the bottom, we know that African American women have higher rates of triple negative breast cancer. I'm going to talk more about that at the end, but just keep that in the back of your mind. Mammography rates, but also lower uptake of genetic testing. We know that as a fact. I'm going to talk about that more in a minute. Social relationship. There are not as many positive role models for early detection or genetic testing in that population, and I know because I have had women tell me cancer is a death sentence. And so the reason for that is because when women in that population are diagnosed with breast cancer, they're diagnosed at a later stage. So they have no positive role models for early detection or genetic testing. And our colleagues in Chicago also found that there were either no mammography or poor quality mammography facilities located close to where African American lived in the south side of Chicago, for example. And the top level is lack of policy on mammography, genetic testing, or treatment quality assurance acts. All right, so these are some risk factors, and they all have evidence for these in the literature. So how can we address these levels? Well, let's go on the right side, which are the intervention levels. Legislation can be enacted to assure access to genetic testing, quality treatment, and follow-up. And based on the results of the study my colleagues in Chicago did, they worked at the grassroots level to get legislation enacted to improve the quality of mammography. They also got navigators hired to assist with follow-up. Navigators can also assist with genetic testing. They also enforced the act that they had passed. Another level, let's go down to mobile mammography, and you'll hear more about that, how we do that in Ohio. And now our genetic counselors are actually using telemedicine for genetic counseling and referral to genetic testing. On the social relationship level, you can use peer navigation. You're going to hear more about that too. Individual risk factors: increased mammography, increased acceptance of genetic testing, and we'll talk about that at the end. And the bottom level, of course, genetic counseling and testing with recommending surveillance based on the individual risk. So this is just an example how we can identify the risk factor levels and then identify interventions to address each of them. All of these levels, again, interact together. The goal: reducing disparities. All right, now let's move into some topics in prevention, screening, and survivorship. Prevention. What do we know that we can do to prevent our risk of developing cancer? Number one, tobacco. And here we're talking about cigarettes, smokeless tobacco, vaping on the increase. And you can see the cartoon on the right. About 19% of cancer diagnoses are caused by smoking tobacco. Next is alcohol and binge drinking, which actually is something that we have found very high in young women, binge drinking. And you can see again in our cartoon, about 5.6% of cancer diagnoses are caused by alcohol consumption. Infectious agents: hepatitis B causes liver cancer. Human papillomavirus causes up to 6 cancers. Most commonly, you've probably heard of cervical cancer, but oropharyngeal cancer too is on the rise. Obesity, diet, physical activity. We can see it on our cartoon on the right. Excess body weight, about 7.8% of cancer diagnoses are related to being overweight or obese. Diet, 4.2%. Cancers related to having poor dietary habits, and physical inactivity, 2.9% of cancer diagnoses are related to getting insufficient physical activity. Next, I have sun exposure, and that's about 4.7% of cancer diagnoses. And this is not just from the sun, but also tanning devices. And I have a couple of others listed here: genetic risk. Many of you heard of Lynch syndrome, for example, or the BRCA1, BRCA2. And then environmental exposures, which is also included in that 3.3% related to cancer-causing pathogens. Goes back to our infectious agents, but also environmental exposures like radon and other carcinogens. In the area of screening or early detection, and again, remember, screening, the goal is to catch the cancer early where it can be treated. So the most common screening tests we know of are breast cancer, and that can be with mammography, or at high risk, MRI might be added, and also clinical breast exam. And if you look at the cartoon on the right, you can see that in 2015, 28.5% of women ages 50 to 74 were not up to date with breast cancer screening. And that is the age of screening, 50 to 74. Cervical cancer, the U.S. Preventive Services Task Force has recently changed that so that women can get HPV testing alone or HPV testing with cytology. And you can see on the right, 17% of women ages 21 to 65 were not up to date with cervical cancer screening. And again, that is the recommended age. We can go to colorectal cancer next. There are stool-based tests like FIT or Cologuard and colonoscopy. And 38% of adults aged 50 to 75 were not up to date with colorectal cancer screening. And that's a little distressing, because screening for colorectal cancer, not only can you detect a cancer early, but you can actually detect a precancerous adenomatous polyp, which, if detected and removed, can actually prevent a cancer. So that's very exciting for colorectal cancer screening. However, we're not even at 80%, which is what the goals for Healthy People 2020 and 2025 are. Lung cancer screening, kind of the new kid on the block, and that has being done with a CT scan. And in the cartoon, it says 96% of adults ages 55 to 80 who have smoked at least one pack of cigarettes per day for 30 years and who currently smoke or have quit within the past 15 years are not up to date with lung screening. So that tells you who's eligible. They've actually just dropped that to 20 years. You can see only 4% are not have been getting screened. And lastly is an annual skin examination, especially important for those who are at high risk for skin cancers. And the last area is survivorship. And I like to use the definition for survivorship as a person being a survivor. Person is a survivor once they are diagnosed with cancer. And so where are areas that we see disparities in the area of treatment in terms of delays in diagnosis? I'm going to show you some data for that. Disparities in access to proper treatment. This is especially important based on where you live or based on what insurance you have or don't have. And during treatment, we see side effects, physical, emotional, financial, etc. And we see disparities in the treatment of these side effects. After treatment, there are things such as fear, failure to follow up with required health maintenance and surveillance, long-term side effects, and recurrence. And all of those need to be addressed in the period of survivorship. Okay, let's switch now, and I'm going to tell you a little bit about our communities in Ohio. I'm going to tell you a little bit about our Center for Cancer Health Equity, which is our community outreach and engagement arm of our cancer center, and also introduce you to some of our community partners that help us actually address disparities in Ohio. Our catchment area is the state of Ohio, which has 88 counties and 11.7 million people. In Ohio, we have several urban areas, which are represented by the red dots, and 50 of our 88 counties are non-metropolitan or rural, with 2.4 million residents, representing 21.8% of the population, or 59% of the land mass. We also have 32 counties in the east and south that are part of federally designated Appalachia. These areas are healthcare professional shortage areas and also are socioeconomically distressed. We also have several unique populations, such as established and new immigrant communities. We have the second highest Somali population, the highest Bhutanese population in the United States, Nepalese, Asian, and Hispanic populations. We have Amish population in our rural and Appalachia communities, and we also have sexual and gender minorities. In the state of Ohio, these numbers indicate that we are poorer, less educated, and less racially and ethnically diverse than the rest of the United States. The cancer burden in Ohio is higher than that in the United States. The first map here on the left shows the incidence rate of cancer for all sites and types combined. The darker areas indicate the higher rates, areas with higher rates. And you can see that that is predominantly in the south or part of Appalachia, as well as rural counties. This map, shows the same, but for mortality rates. And the picture is almost identical, with the highest burden being in the rural and the southern counties. This is my staff from the Center for Cancer Health Equity, and you can see that they represent all of our catchment area populations. These are some of our community partners. This is our urban community advisory board, and then our organizations that we partner with. Some of the 250 are shown here. And for our rural and non-metro counties, we work with our Rural Community Advisory Board, and we also partner with 44 clinics in non-metro areas. So now I'd like to go through some examples of how we are addressing disparities. The first is our continuum of care navigation. We know that barriers to cancer care have an impact on patients being able to comply with what their doctors have recommended. Some of the barriers patients face are listed here: finances and health insurance issues, transportation, basic needs, food, shelter, utilities, language and health literacy, as well as addressing our non-English speaking population. Barriers also include lack of knowledge, different culture, and fear. The healthcare system itself is a barrier, as are comorbidities, which often prevent patients from coming in and keeping their appointments. So therefore, the impact of these barriers are cancellations and no-shows, which causes failure to receive treatment, as well as non-adherence to preventive behaviors, all of which result in poor outcomes or disparities. Our solution to the barriers that patients face is patient navigation, and the populations that we work with are racial and ethnic minorities, Medicare and Medicaid patients, those from rural and Appalachian areas, both in the medical center and in our cancer hospital, the James clinics. You can see pictures of our navigators on the right, and what we call our navigation is continuum of care navigation, which I'll explain in a minute. And we wrote this up in a paper that was published in the journal Cancer last year. Well, does patient navigation work? Yes. There is overwhelming evidence that patient navigation can reduce delays to receiving follow-up care for cancer abnormalities, reduce delays to starting cancer treatment, reduce patients' loss to follow-up. There are policy implications for patient navigation in current laws. However, patient navigation as it stands now is not reimbursable. So we are looking to see if we can implement patient navigation remotely using telephonic navigators in the clinic and across the cancer care continuum from community to clinic. So when I talk about continuum of care patient navigation, it is from community to clinic. So, for example, we talked about prevention, education, risk factors, and screening. So we can have our community health workers go into the community and educate members of the community about the need to get screened. And once we find somebody who wants to get screened, needs to get screened, community health workers link the patient with the patient navigators who function out of the clinic. And they facilitate the screening. If there's an abnormal screen, they work with the patient to make sure the patient gets resolution, diagnosis, and is able to start treatment and conclude treatment, receive all of treatment, and follow them into survivorship. This partnership between the community health worker, the patient, and the navigator is seamless, culturally competent, make sure that during the transitions from screening, abnormal screening, diagnosis, cancer diagnosis, and treatment are smooth. At each step, the navigator addresses the barriers the patient has, resulting in adherence, same time maximizing communication and networking not only with the community health worker, but resources in the community that can address the barriers and make sure that the patient is adherent to treatment. I now just want to show you a couple of projects that we've done using our continuum of care patient navigation. The first was funded by Komen. Its focus was on community outreach, mammography, and follow-up of positive screens. This happened both in our freestanding breast center as well as on our mobile vans. And the second project is the Ohio Breast and Cervical Cancer Early Detection Program. This program is funded by the Ohio Department of Health through the CDC and provides community clinical linkages for breast and cervical cancer. It uses both Komen and program screening dollars to support age-appropriate screening for those women who qualify. So for the mammography continuum of care, we focused in counties that have high late-stage breast cancer rates, limited mammography facilities. So in this map of Ohio, in the Appalachia area, you can see that we have several counties that have no mammography facility. We also, again, included our breast center, the mobile vans, and provided follow-up. So in the 5 years that I show here, we had over 2,600 mammograms conducted with 48 cancers detected. And in terms of time to diagnosis, you can see in that baseline, time to diagnosis, those diagnosed within 30 days was 87%. The current year of the program got up to 95%, so 95% of the women were diagnosed within 30 days. We increased those diagnosed within 60 days from 91 to almost 97, and increased those diagnosed within 90 days from 93% to 98%. And it's very important to have a woman be diagnosed soon and then be able to start treatment. We actually have data showing that over 60 days has a significant impact on probability of dying. And then for the Ohio Breast and Cervical Cancer Detection Program, I'm showing some results here. These are by zip code. We were specifically asked, our navigator was asked to work in specific zip codes because the Ohio Department of Health knew that there should be more women in certain zip codes enrolling in the program. And we were responsible for a 51% increase in enrollment into the breast and cervical cancer early detection program, allowing more women to get mammograms and pap tests. I now want to talk about one program we have that focuses on the area of survivorship, and this is adding technology to navigation. And this is led by my colleague, Dr. Michelle Naughton. So the program is designed to improve symptom management, quality of life, and quality of care of newly diagnosed cancer patients at our cancer center. We targeted 4 cancers: endometrial, ovarian, breast, and lung. So the objectives are to develop and refine this integrated communication system for newly diagnosed patients and their providers, and it uses the OSU MyChart, electronic health records, cell phones, and navigator support. And what we do is systematically monitor patients' physical and emotional symptoms bi-monthly. We get data on pain, fatigue, sleep difficulties, and depression using a text messaging system. And then the patient reports of these symptom levels and other needs are monitored by patient navigators and clinic staff with appropriate follow-up by the healthcare team or referral to other supportive services. And the goal is to increase patient adherence to all visits, and that is done by using text messaging and email reminders with the navigator as appropriate, and to increase patient health-related quality of life and treatment satisfaction. So this is designed using a smartphone, text-based symptom monitoring, that is the communication system. Patients who don't have a smartphone are provided with a phone And the patients receive bi-monthly texts that they complete, where we include these screening questions to assess for difficulties in pain, assessing sleep quality, and global quality of life. Now, this is in addition to their regular in-clinic monitoring through their regular visits. We record the responses in our data capture system called REDCap, and we notify the healthcare team about any patients who have high symptom values. And this is done automatically to a clinic nurse and as well as the navigator. This is just a schema representing what I just mentioned. So there's monthly symptom and other concerns survey that the patient does, and the symptom alert is sent if the values are high. Those are reported to the physician and staff. Other issues are sent to the patient navigator. The patient navigator addresses non-clinical issues such as gas cards, community supportive services, and utility issues. And if there's a need for just a person to talk to, the patient navigator can do that. When the patients sign on to the study, they're also encouraged to sign up for a MyChart, as well as text message reminders for clinic appointments. This is just a brief update of how we're doing. So we piloted the study. We started in the gynecologic and breast clinics, and then we expanded to thoracic oncology and thoracic surgery. And we are now following up with 15 thoracic surgery patients. And then in year 5, we're doing something new. We're expanding to breast metastatic patients, a growing population. So with the metastatic patients, what we want to do is assess the symptoms and the need that they have during treatment, provide navigation services, and actually really we want to learn more about what is going on with these patients in terms of ongoing concerns and needs in the long-term metastatic breast cancer patients. So in addition to enrolling patients who are on treatment, we want to enroll long-term metastatic breast cancer patients because with the new treatments, we're actually seeing more long-term metastatic breast cancer patients, and we want to learn more about them so that we can help them. So this is the eligibility. As you can see, we have 3 cohorts: those newly diagnosed, those transitioning from oral to IV systemic therapy, and then long-term survivors. This is an area that we need to know more about. So I'm going to tell you a little bit about what we found. We have developed the monitoring system. It's relatively low cost. It can be tailored. It's flexible. It's easy to maintain and user-friendly. Over 76% acceptability by both patients and providers. And the physician referral of patients that they believe really need monitoring works very well. So those alerts work very well. We built on existing resources. For example, we had REDCap, this data program already, and thus we saved time and expense. And this also strengthens the case for sustainability. And teaming the symptom monitoring or technology with navigation really makes this a novel monitoring program. And I would just like to thank the team that are conducting this project, and you can see it's not just the PhDs, the MDs. We have great staff and a statistician who are helping us conduct this study. All right, my final example I want to talk about is our initiative called Turning the Page on Breast Cancer. I'm very excited about this. I do need to tell you that we started this. We actually had our big group meeting with American Cancer Society in February of 2020, and then COVID hit. So as you'll see, we're a little delayed, but we're real excited about this. This is a community-wide study and really was designed to address a great disparity that we see in Ohio as well as is seen in the United States. So breast cancer is the most commonly diagnosed cancer in the U.S. amongst women. 1 in 8 women will be diagnosed with breast cancer in their lifetime. That means every 3 minutes, a female in the U.S. will be diagnosed. In 2021, you can see over 281,000 new cases of invasive breast cancer will be diagnosed, as well as about under 50,000 cases of ductal carcinoma in situ. Although breast cancer incidence is similar between black and white women, breast cancer death rates are 41% higher in black women than white women, as shown in the figure on the right. You can see that for death rates in non-Hispanic black women, the rate is 31 per 100,000 women, higher than any other racial or ethnic population. In addition, 5-year breast cancer survival rates for black women are 78% and for white women, 92%. Why? Well, there are many possible reasons for this disparity, including biologic and genetic differences in tumors. So this goes back to the model I showed you earlier. Higher rate of triple-negative breast cancers in African American women. Different prevalence of risk factors. Specifically, what has been talked about is obesity, for example. Lower rate of genetic testing. Barriers to healthcare access, including barriers to screening and follow-up after a positive. Health behaviors that increase risk, and later stage of breast cancer at diagnosis. If we now go into some of the reasons for disparities, the first one I want to talk about is triple-negative breast cancer. And we can see from this figure on the right that black women are more likely to be diagnosed with triple-negative breast cancer even at all ages. You can see the blue bars there. And overall, the rate of triple-negative breast cancer per 100,000 is almost twice that in black versus white women. Talk about disparities in outcome for a minute. Even among patients with triple-negative breast cancer, black women have worse outcomes. And these are survival curves that you can see here on the right. And Dr. Naomi Coe and her collaborators stated that nearly half of the observed racial ethnic disparities in higher stage of breast cancer diagnosis are mediated by health insurance coverage. Again, health insurance causing this difference in stage of diagnosis, which leads to worse outcomes. Let's talk for a minute about disparities in genetic testing. We know that women with hereditary cancer syndromes like BRCA1 and 2 have a very high risk for developing cancers. And these women can benefit from intensive cancer surveillance and prevention options, but they have to know that they have the syndrome. African American and Hispanic women are much less likely than white women to receive genetic counseling or testing for breast cancer. So, for example, only 28% of at-risk African American women received genetic counseling and testing. And only 40% of minority women with early onset breast cancer have received genetic testing. But if they do receive genetic counseling, minority women are as likely to pursue genetic testing as non-minority women. So if they're given the option, they're just as likely as non-minority women to get tested. What are some of the barriers to genetic testing? The number one that we hear all the time is cost. Cost should not be a barrier, but it is. It is mostly cited among Latinos as the cost or out-of-pocket expenses. However, we do have good coverage from third-party insurers, Medicare, and some Medicaid plans. And in addition, there are generous financial hardship programs offered by testing laboratories. The problem is not everybody knows that there is genetic testing, and that becomes a barrier. minorities have lower awareness of genetic testing, and this awareness is influenced by education level, access to healthcare services. They have access to a physician who knows about genetic testing and knows that it can be covered by some health plans. Lifestyle, socioeconomic factors, and acculturation. Access is a barrier, though, and I mentioned the access to a provider who can refer. But 1/3 of African American women at high risk for hereditary breast cancer have not been referred for genetic counseling and testing. And physicians whose patients were mostly minorities were less likely than other physicians to order genetic tests. So that speaks to the fact that the physicians, healthcare providers need to be educated about this. So let's move to breast cancer screening. What are some of the barriers? Fear of the costs, both of the mammogram and of cancer. Fear of receiving bad news. Fear of pain or discomfort with the mammogram. Lack of transportation. Distrust of the medical system. And social norms, expectations, beliefs, etc. And then lastly, I want to talk a little bit about the fact that Black women are diagnosed at higher stage of diagnosis. And you can see this, that white women are more likely to be diagnosed at stage 1, and Black women, it's stage 2. And at all levels, Black women have higher rates other than stage 1. So putting this all together, we can actually construct a disparities model for triple negative breast cancer, pointing to the fact that access to healthcare, individual reproductive factors, unsafe neighborhoods, environmental levels, socioeconomic factors, and comorbid diseases all impinge upon this to cause disparities in triple negative breast cancer and poor survival. So what are we doing? So we are hoping to reduce the burden of breast cancer in 12 counties in Ohio that have an excessive burden of breast cancer among African American women. We are doing this by utilizing a multi-level approach. Again, I talked earlier about multi-level approaches. And we're providing breast cancer risk assessment. We're facilitating adherence to screening based on the risk assessment, including referral to genetic counseling and testing for those women who need it, and prompt and appropriate treatment. And this is being done in a new type of research model called implementation science, where we suggest multi-level evidence-based interventions based on the need of each of the clinical partners who are working with us. We are working in 12 counties in Ohio, and we identified these counties as those with higher rates of African American women and or higher rates of breast cancer in these counties. Our approach, I mentioned, we're using a multi-level implementation science design. So we're focusing on the clinic or the health system. And in the clinic, we work with the providers and the patients. And in addition, we're also working with community organizations in the community. So we're contacting and identifying clinics that want to work with us in each of these counties, as well as community organizations. We go in the clinics, we identify the baseline rates of genetic testing referral, mammography, follow-up, etc. Do you have a process for monitoring who you refer to screening, if they got screening, and did they have a positive, and are you following up with positives? We're then, based on what we find, proposing to them some evidence-based strategies that they can implement to address some of the barriers for being up to date on all of those areas. They're asked to select a clinic champion and a team, and then the champion and the team decides how to implement the strategies, and all of them will be getting a CME presentation. We'll be looking at the rates again of these variables over time, and also at the community level conduct community events. And our the main thrust is to direct women to a study website. So where are we? We have established partnerships with clinics in 10 of our 12 counties. We've obtained baseline screening rates and clinic characteristics. We have created a CME accredited recorded presentation to educate the providers about breast cancer and genetic counseling. The provider education sessions are being set up, and we have finalized our promotional items with a QR code and website address. We have been conducting key informant interviews, and some of the emerging themes we've seen is that most clinics do not routinely recommend genetic counseling to their patient population, something that has been documented in the literature, and there needs to be better follow-up tracking systems to know when women get mammograms, if they have abnormal, if they need follow-up. We're based on that, providing clinics with evidence-based interventions, and we're helping them to implement a tool in their electronic health system so they can see if a woman is at high risk for breast cancer. The sites are now implementing our risk questionnaires and doing referrals to genetic counselors in their daily practice. And one site that did not follow up with women who had an abnormal mammogram is now implementing a process in their electronic health record to follow up with these women. The address to get to our website is listed at the bottom. And since November, we've had over 5,000 page views and 54 women have completed their risk assessments. Now, on the screenshot on the right, you can see what is included in the website, including information about breast cancer, information about Black women and breast cancer, information for providers, and some additional resources, which include where to get mammograms and treatment in each of the 12 counties that this project is being conducted in. In addition, women can go and do the screening tool that determines the risk for breast cancer, which I'll show you the questions in just a minute. There are some featured articles and messages from the community, specifically women with breast cancer, and then how to contact us. This slide shows the 7 questions that we use as our screening tool, mainly the family history screening tool. And it asks about specific cancers in first-degree relatives and other relatives. And any positive response initiates a referral, meaning a higher than average risk for developing cancer. So women can go to this website and they take the personal risk assessment. They can find out more about breast health. We have a lot of information there. Find out where and how to schedule a mammogram. We have links that they can go to about facilities in their communities, and then it can also connect to community resources. So I think that this project really is demonstrating how we can address disparities at all levels. I want to thank our team because this is a big project. It takes a lot of team members to put it all together. But again, this Turning the Page on Breast Cancer demonstrates that disparities exist at all levels across the cancer control continuum, and that we can institute levels across all of these levels in order to address these specific disparities in our population. Thank you very much. I'd be happy now to take any questions.